So I think we'll stop the discussion here and look at some of the data. Dr. Riziri, if you could walk us, please.
Sure. You brought up the issue of CPX-351, so let's look at that with our audience members in a little bit more detail. This is a Cytarabine Daunorubicin liposome using a nanoscale delivery complex. You see the picture of the liposome noted here, where it's a 100 nanometer bilamellar liposome. It's a 5-to-1 molar ratio of cytarabine and daunorubicin, which in preclinical work was felt to be the synergistic ratio. And so the neat thing with this delivery mechanism is to take advantage of a ratio that is felt to be most synergistic in such patients and also potentially increase the delivery of the agent to the area of concern, primarily the bone marrow. And you see that 1 unit of CPX-351 is equivalent to 1 milligram of cytarabine and 0.44 milligrams of daunorubicin. We see the phase 1 data here for this fixed molar ratio the ratio was maintained for 24 hours after the final dose. The drug exposure was maintained for a week, and with that we found potent anti-leukemia efficacy, and it was well tolerated. And that's what led to the phase 3 study as indicated here. This is a phase 3 prospective randomized study of CPX-351 versus standard induction in older patients with newly diagnosed high-risk secondary AML. And we do use the term secondary here, even though it's been stricken from the current WHO classification, because at the time this study was conducted, that was still in our vernacular. So the primary eligibility was to have patients who were previously untreated for AML, age 60 to 75 years of age, and able to tolerate intensive chemotherapy. Patients were stratified between those who had prior therapy-related AML, AML with a history of MDS with or without prior HMA therapy, patients with AML with a history of CMML, and de novo AML patients with MDS karyotype. There was also an age stratification of 60 to 69 years of age and 70 to 75. And you see that patients could receive up to 2 cycles of induction, and those with a remission then went on to receive consolidation therapy. And the primary endpoint was overall survival. You see the dosing as noted here for first induction and reinduction, and fairly standard dosing for 7 and 3 as well. If we move on to the baseline characteristics, I'll give you a second to look at that, but they are primarily very similar populations, I believe. Similar groups of patients by age range and performance status. If you look under the clinical characteristics, we may want to look at those with antecedent MDS and with or without prior HMA therapy. This is a group that's of some concern to many of us, and you can see they were fairly well balanced. FLT3 mutation, a little bit more with FLT3 positivity in the CPX-351 arm, that high-risk group we have talked about before. Breakdown by white count, similar, and platelet count as well. And the overall responses noted in the next slide were really encouraging. You see, based on full CR or CRI, that incomplete responding group, 37 to 47.7% CR or CRI rate in the CPX-351 group, versus 25.6 to 33.3 in the 7+3 group. So that's encouraging, but I think the other key here is it tolerable? We talked about these patients being primarily older. They may be more infirmed. And you can see in the next slide the early mortality rates, 6% and 11% respectively at day 30, and 14 and 21% by day 60. If we move to the meat of the primary endpoint, survival, in the next slide here, we can see patients with CPX-351 having a median survival of 9.56 months versus 5.95 months in those receiving 73. That's a statistically significant difference, 0.005. But importantly, when you look at those curves and the difference, I think that's a clinically meaningful difference for our patients as well. Now, if you look at a Kaplan-Meier curve for overall survival and for those landmarked at the point of stem cell transplant, the IIT analysis population is noted here that the median survival of the CPX-351 patients was not reached, and those with 7 and 3 was 10.25 months, also with a clinically and statistically significant difference. And this is as presented by Jeff Lancet at ASCO a couple years ago. So I think here's a phase 3 prospective randomized study showing a survival difference. And I think we have very few of those in our specific field, and so that's very encouraging. But what cost does it come at? What are the side effects and toxicity? The next slide shows the febrile neutropenia, fatigue, pneumonia, bacteremia, and sepsis issues that we follow. And I think it's very comparable in these objective measures for side effects in these two groups. And if we move to the next slide, in terms of count recovery, this is one of the main differences that we've all noticed as we roll out CPX-351. It takes about an extra week to recover your counts, and so we really want to preach patience for these patients. Notably, in particular, if you're used to doing a nadir marrow at day 14, if that's important to you, you probably want to delay that, as we did on study to day 21 or so. But these patients will recover. It's just about a week delayed. And so the conclusion from the phase 3 study of CPX-351 versus 7 and 3 is that older patients with high-risk secondary AML had longer overall survivals with CPX-351 than 7 and 3, and longer overall survival when even landmarked from patients undergoing transplant. The post hoc analysis showed a greater proportion of patients with CPX-351 achieving a CR or CRI, that's 47 versus 36%, and more of those patients underwent transplant. And patients receiving consolidation following successful induction also had longer survival with CPX-351 versus 7+3. So the last two slides of this look at the safety of this combination. It's a fairly busy slide, and I'll give you a minute to look at that. But there really isn't anything when you look at all grades of toxicity that jumps out at me as different in this particular presentation. I'll be interested in my colleagues' views of this, because all of us have a sense from treating a lot of these patients that it is better tolerated. We're talking about a lot more outpatient home therapy, and not for nothing, my patients love not losing their hair. So maybe that's why they feel better when they look in the mirror. That's not a bad thing.